Good afternoon, and thank you all for joining us for the second session, I do believe, in this track Continuum of Care. We are very excited about this session. We have a couple of great speakers that we hope you'll enjoy today. The purpose of this session will be to address the tools and resources that are currently available to reduce the substance use disorder. As I mentioned, we have a couple of great speakers. We have Emily Mitchell from Accenture Federal Services, Berlin Hock from Utah Navajo Health Systems, Ron Larson from the State of Utah, the Department of Commerce, and then we have Rose from Consulting Group. Then we have Jeannie Hines, Associate Chief Medical. And lastly, we have Jamie Smith from SureScripts. Again, I want to thank you all for joining this session in particular. And with that, we are going to get started. We wanted to start off this session by kind of going through and giving you a couple of updates on prescription drug monitoring program and electronic prescribing of controlled substances activities. What ONC has been working on, which some of you may have known already, we had a project in which we had an initial scope of developing the PDMP HL7 Fire implementation guide. And the purpose of this was to enable EHRs to access PDMPs by mapping the standard, the version 10.6 and the PMIX version 1 to the HL7 Fire version. And that version was the R3. And the point was to create an implementation guide. With this project that we completed this summer, we created and refined some mappings between the NCPDP script standard version 2017-071. We also updated the 2015 ASAP Prescription Monitoring Program Web Service Standard 1A. And lastly, we updated that implementation guide so it was the standard version R4. As we wanted to make sure that as this implementation guide was developed or enhanced, that we were preparing all new and updated mappings for future balloting. And so that update for that HL7 Fire implementation guide was to provide guidance for a fire-based exchange between PDMPs, EHRs, and other electronic prescribing systems and pharmacy systems. Now, we know that there are a lot of exchanges that go for prescription drug monitoring program data or PDMP data. That information can go from the pharmacy, CHRs, or some other kind of app to the state PDMP, and then you also have that exchange between the state PDMP and the pharmacy. For this project, our specific focus of interaction was that of interaction number 3. That's currently in the scope for the US Meds Fire PDMP implementation guide. And as you can see here, that the focus again was on that NCPDP script 10.6 Fire version, and then that going to the NCPDP script 2017-071. So we did the work to update these mappings. And so what we're looking to do is include the implementation guide into the HL7 September balloting process. And we hope people will consider updating the PMIX mapping table if that PMIX version 3 is finalized. These slides will be available after this presentation. And what we have here is the current balloted implementation guide. So you can go to that link and look at this implementation guide in detail. Along with piloting some of the work that has been updated, we also want to take a focus on something different than we've usually done with our pilots, is actually focusing on that ASAP web service standard that was in the previous transaction for transaction number 2 for the state PDMP and the pharmacy. Some things as we think about the 21st Century Cures Act, we know that that was developed to look at interoperability, information blocking, and the ONC Health IT certification program. With that, we were able to update the electronic prescribing script standard in 2015, in the 2015 edition from the NCPDP script version 10.6 to the new version. As we continue to make these updates, it's important to know that we are working with CMS as we make these updates. And for CMS, their part is they're actually finalizing is Part D standards to this new standard in medical history. And this became effective on January 1, 2020. So we hope to maintain this relationship and make sure that we keep working together so that we have complementary policies and that we align our standards as we go forth. So some things that you can look to in the future is looking at ONC to continue to reference this current transaction. And we will look to propose to require all the NCPDP script 2017-071 standard transactions as CMS adopts. One other thing to keep in mind is that we've also updated the ISA. We've updated it with a specialty care and settings functionality for the opioids and pediatrics, which you may have heard previously. And listed here are just some of the things that prescribers are allowed to do that I won't run through because you can read. And then you can see the final one that it allows for the exchange of state prescription drug monitoring program data. Once you go to our ISA page, you can go to the page and you can see way at the bottom where it has the specialty care settings. And once you click on that, it'll take you to a screen that allows you to see the different standards and where they are in the process for exchanging of state prescription drug monitoring program data. These are just some things as far as looking at electronic controlled substances in NCPDP script. To make you aware of, the DEA is currently testing to the script 10.6 or version 10.6 for EPCS, although NCPDP released the version 1.0 of their PDMP reporting standard implementation guide in January 29 in 2019. This version has been developed for the use of batch electronic subscription. And then you can see that over the years, the script schemas have been updated to support various transactions. And we will probably have Jamie to go into more detail about the ESPCS work or space. And with that, those are just some of the quick updates. If you have any questions about any of the things that I mentioned, you can contact myself or Carmen Smalley or Lolita Cachet, as well as Al Taylor, who is also on here as well. And with that, I am going to take a step back and let you hear from the people that you probably came to hear from. I will start with our Emily Mitchell, who is with Accenture, and what she'll be doing is talking about our project that supports the PDMP integration, the Advancing PDMP and EHR Integration Project. And she'll also have Berlin as well as Ron to support her to give us some information on what that looks like from the pilot site perspective. So with that, Emily, please take it over.
Great, thank you, Joanna. So again, this is Emily Mitchell. I'm the senior manager with Accenture. I am the program manager for the Advancing PDMP and EHR Integration Project, which is a collaboration between ONC and CDC. The goal of the project is to help advance and scale vendor-agnostic, standards-based approaches to PDMP integration with health IT systems. So to do this, our project team is coordinating with 6 different healthcare systems across multiple states as those health systems integrate their EHR with their state's PDMP. Separately, we'll also be partnering with 2 healthcare systems who will be implementing standards-based CDS tools to facilitate the recommendations from the CDC guideline for prescribing opioids for chronic pain. For today's discussion, I'll be focusing more on the PDMP and EHR integration portion. So our project's goal is to help augment states' efforts to enable clinician use of PDMP data. A lot of different states already have efforts underway, so we are working with those states to understand the current state, identify what gaps there are to help them roll out a broader scale and simplify the process for healthcare systems that want to integrate with the state PDMP. So as our partner sites are going through the implementation, the testing, and the refining of their standards-based non-proprietary approaches to integrate their EHR with the PDMPs, our team is looking at what sort of impacts that has on their clinical workflow, and we're working to develop reproducible processes and resources that can be shared with other healthcare systems and states down the road so that they can learn from those best practices and challenges that our partner sites have gone through. Some of our current in-progress demonstrations include Utah Navajo Health System. I'm very lucky to have Verlin Hawks from Utah Navajo on the phone to talk a little bit about his integration. UNHS went live with their PDMP and EHR integration back in January, so we've seen some good results over the past several months with them. We're also currently working with Baptist Health and Grace Health, both in Kentucky, as they integrate their EHRs with the Kentucky PDMP, which is called Casper. Baptist recently went live with a small-scale ambulatory pilot in July and has seen some good feedback from that. They're planning to roll out more broadly in September. Both of these sites, both Baptist and Grace, had planned to go live earlier this year, but unfortunately with the impacts of COVID-19 had to defer some of their target dates. So Grace will also be launching sometime this fall. And another upcoming demonstration is Nemaha County Hospital, which will be integrating with NEHI, the Nebraska HIE and PDMP. As we work with each of these healthcare systems, we'll be conducting an evaluation to understand metrics before and after integration and try to assess the impacts of that integration. So comparing things like the number of PDMP queries that are conducted through the portal from the start before they've gone live with the integration, and then understanding what those query counts look like after the integration. We're also very interested in seeing what the clinician feedback is, understanding if they're satisfied with the workflow changes, if they have feedback on the interface, and also looking more broadly at impacts to the average MMEs for the organizations. Our team is also going to be capturing all the different challenges that the sites go through. So understanding what are the technical challenges, what are some of the workflow challenges. As the organizations are conducting their integration, we're seeking to understand what are some of the design considerations, what are some of the activities they have to go through to get organizational buy-in, how are they conducting training, what sort of communication messages do they have, so that we can pull together a checklist of activities that other systems should do as best practices or might want to consider as they embark on their own integrations. Really, we want to be collecting the success stories of what helps lead to a successful go live, what sort of enhancements do they have after it's gone live, and how are they impacted by different bugs? What are some of the cost and time savings over time? And through all this, our team will be producing a toolkit with checklists, tips and tricks, test guidance, memorandum of understanding considerations, and other guidance that can help healthcare systems and states based on the best practices and learnings. One of the items our team has been working on is what we call the integration taxonomy item. As we've worked with all of these different states and sites, we've observed that there's a lot of different understandings of what PDMP and EHR integration can entail. The definition has varied widely, and so we've divided that integration definition into 5 different key components: access, querying, display, storage, and analysis and use. And so as we talk to each of the sites, we seek to understand when they're talking about integration, is this something where the access requires them to enter credentials like you would do on a current PDMP portal, or is it something that's a single click where it automatically launches you into the PDMP data building on your EHR credentials? And when we talk about querying, does that mean ad hoc queries kind of on demand as the clinician wants it, or does that incorporate some sort of automatic or scheduled batch query? We're seeing some sites where they choose to run queries, for instance, at midnight the night before for anyone who's scheduled to come in for an appointment the next day. Other systems choose to do more of an on-demand opening a report at the time that a clinician needs to look at the report. We've also been discussing display. So is it a static document such as a PDF that the clinicians can see coming from the PDMP, or is it a more dynamic interactive type report? Another component is storage. So this varies based on what is allowed by the state's regulations, but trying to understand, is any of the PDMP data actually stored in the EHR, or is it all still residing within the PDMP? Some states allow it to be stored as a PDF. Other states might have different levels of what they allow. And then finally, the analysis and use. Are any of the healthcare systems able to take that data, especially if it's a discrete type data, and run any sort of business logic on it that can help generate things like clinical decision support? So those are some of the things that we've been talking to the sites about. And this framework basically helps us just kind of confirm what each site means when they talk about their own integration so that we can structure some of the materials around those approaches. We've also been working on a testing guidance toolkit item. So based on some of the sites that have undergone testing so far, we've been collecting examples of different things that they test for, some of the things that have developed issues so that we can help other systems to test for similar things. So this toolkit item that we've created collects test scenarios, lists potential data elements that, depending on how you've integrated, might be relevant to test, helps collect potential errors in a template for an error tracking log, and provide sample test session test scripts. Some of the observations we've had from the testing that we've worked with so far has been the importance of understanding the full clinical workflow, so that when they're testing, you don't want to just test for the PDMP integration functionality, but also understand what other components of the workflow might have been impacted and test accordingly. So things like the EPCS workflow, understanding what might need to be tested. And so it's been really important for the build teams and the test teams to get input from clinicians and providers so that they have the full picture of the clinical workflow that is touched by the PDMP integration. It's also important to have a thorough list of user profiles and test all of those. You want to make sure that the folks that should have access get it after go live, and the folks that should not have access, test to make sure that that is restricted when it should be. And I think we're seeing just the importance of having prepared test scripts and test patient data in advance can help make your test sessions much more efficient. And really, it's an ongoing process, as we've learned from especially our collaboration with Utah Navajo. Every time there's a new enhancement rolled out or different EHR upgrades, you want to make sure you're keeping an eye on, are the PDMP integration components still working, or are those somehow impacted by other things that might be changed? So those are just some of the initial observations, but all of these things are going to continue to be tested as we work with each of our different partner sites, so that when we get towards the end of the project, we'll have a toolkit that can be shared more broadly with other parties so that they can help, they can be assisted in their own integrations. So at this point, I will hand it over to Verlin Hawks from UNHS to talk a little bit about his integration.
Okay, thank you, Emily. Good afternoon, everyone. I want to first, First, just give a brief introduction into Utah Navajo Health System. It's a unique organization in a unique setting. It was formed in 2000 to serve the Utah portion of the Navajo Reservation. We serve the tribal chapters and communities there. We operate both as a contractor to Indian Health Services as well as a federally qualified community health center. We've got 4 medical clinics, 5 dental clinics, a vision clinic. And because of the remote nature of where we are and the lack of other facilities in the area, in addition to our regular services, we have to have our own full labs, our imaging center, we have pharmacies, and we provide our own ambulance, EMS service, as well as patient transport. And to give a further indication of how remote we are, we also have to run our own microwave network to connect our clinics and tie them back to the site that has fiber. If you look as to where we're located, you'll see, if you've ever heard of the 4 corners of the United States, where 4 states share a common boundary point, but we're right down in the very southeast corner of Utah, roughly serve about 30,000 residents over a pretty large geographic area. And to give a perspective of what it looks like, doesn't all look like this, but if you've ever heard of Monument Valley, this is an aerial shot of our Monument Valley clinic, actually during one of our mass COVID testing that we did in April. But there on the left, it's a spectacular setting, great people. So I wanted to first just give an overview of a little bit of our journey to get here. We actually started in 2017 with the hope of starting to integrate PDMP checking into our EHR. We had just gone to a cloud-based EHR at the time, but as interacting with the state and with the EHR vendor, neither were really technically ready for that. But last year we were contacted after having expressed interest multiple times. We were contacted by the Utah State Controlled Substance Database Administrator and by Emily with the ONC CDC project to see if we would be interested in helping to advance this process. And we jumped at the chance. We knew there would be some limitations due to our setting, and we're not the largest setting around, but we worked with them from last year early till this year and went, quote, live in January. I will admit it felt a little bit more like an integration test or an early beta than going live, but it settled down fairly quickly. We worked with the various vendors, with the state, and the project, CDC, ONC project provided assistance along the way. There were a number of issues that we had to deal with, both access and permission issues, some of the challenges in dealing with the different layers. Everybody seemed to have their own mapping for roles. And then, of course, as you would with any multi-layer architecture, there were performance issues and other timeout issues between the different layers that we had to work through. We also had some audit logging, user interface, data anomalies. So we spent quite a bit of time, frankly, a little more than we thought we would have to, but we spent quite a bit of time helping research, troubleshoot, identify problems. And in March of this year, the implementation really started to stabilize. We had some additional plans, some timings, testing, and then COVID hit. And if you follow the news at all, the impact of COVID has been pretty large on the Navajo Nation. And it obviously, as many other healthcare facilities, it changed workflow, it changed the patient interaction, and it shifted a lot of priorities. We did a number of mass testing events. We had to do a pretty rapid implementation of more telehealth. And when you have limited bandwidth running across your own microwave networks, that creates some challenges. But we have just in the last month or two started to finally get back to some of the PDMP and do some analysis there. So I kind of wanted to approach this a little bit from the point of view of the provider. A lot of times when we look at PDMP efforts, it's focused obviously on the patient, reducing overdoses, misuse, so on. But the providers undergo a lot of stress, really. When you look at what a provider has to deal with, obviously management and finance is pulling them to see as many patients as possible. If you're in the community health center, you become, and many others, you become familiar with meaningful use and MIPS and UDS and on all of those quality measures, and providers are pushed pretty hard in those areas, sometimes perhaps too much, and they get focused more on regulations than they do on the patient, which is where they really want to spend time. But then you introduce some of the state regulations and people wanting them to do PDMP checks for at least every opioid prescription. Some have suggested they should do it for every patient. So I kind of wanted to, I pulled up one schedule just to give a perspective from a provider. This is a real schedule. Obviously, you can't read the names, but you'll see that this provider had 20 patients scheduled roughly every 15 minutes with a break or two in there. And so when you stop and think about asking a provider to check the controlled substance history and everything, some people would say they should be able to do that. It's not that big of a deal. But if you look at the steps involved, they're already logged into the EHR. That's a given. They've got to deal with the electronic health record. But from a portal point of view, as a separate application, they have to log into the state's controlled substance portal. And then if you've ever dealt with your bank and two-factor authentication, you'll know that can slow things down, which we do on this. Then they jump into the search screen. They have to remember the patient's name and date of birth, and sometimes that's not always easy. Then they bring up the patient's prescribing history. They bring up the MME equivalents and the various graphs and things that are available. But then at this point in time, especially in our setting, let's say the provider now remembers that this patient is from Arizona, out of state. So they'll jump back to the search screen, do an out of state search, and pull up those records. And then they have to go back to the EHR and make some note in the EHR that they've looked at the records, make some notes about it. So when you look at the schedule point of view, now if you're taking what we found 3 to 7 minutes of what should be a 15-minute appointment, you can see that really puts a pressure on the provider and makes it difficult for them to do that checking during the visit and sometimes even before. And this is one of the reasons, if you read a lot of the trends in PDMP checking, that providers tend to drop off in terms of how much they actually do. They'll sometimes start to push things and batch up requests. They'll use delegates more, but sometimes don't communicate with those delegates. So it makes it difficult because that's not really what the intent of the PDMP checking was. It was to have the provider be well aware of where the patient is and what needs to be considered. So now that's where the benefit of the EHR integration comes in. You've already got the provider lives in the EHR. They're in there all day. They're already logged in. You don't have to re-authenticate. They've already looked up the patient. They basically click on a link, and it brings up the report and graph. Now, with the current implementation in Utah, we don't get all of the data that you can get from the CSD, and we hope that will come. But here's where, and it's been a great help, and it's really makes it much easier for the providers, but here's where one of the challenges we face is now let's go back to the setting where this provider is dealing with a patient who's from out of state or has prescriptions out of state. The current implementation doesn't support anything but Utah records, and they're working on that, but that's really important for us. But at least they can get some of the records, a majority of them, and at least the EHR will make note and log that the provider has checked the CSD. So there are benefits to it. In general, what we've found is that PDMP checks from within the EHR are taking 1 to 3 minutes, and that includes the time to retrieve, to look over the report, and so on. Again, unless the patient lives out of the area or prescribes out of, or is getting prescriptions out of the area, and then there's a problem. So how much has it really helped us? We expected a few things up front. One, we were hoping to see more providers do checks. Yes, they're all supposed to do it, but frankly, some didn't, and some didn't do it as much as they should, which is the next thing. We expected to see providers checking more often. And what we really are hoping for is that providers are checking earlier, more proactive, sometimes in the visit, so that they have a more interactive visit with the patient about this. We did gather some survey data. We had a great pre-survey on the day that we put out the post-survey. We had an outage, and then COVID hit, and so it's impacted us. But in general, what we found is that one, providers definitely find it easier to use. They rated the post-integration, the EHR version, as with a rating of 4.54 out of 5 as far as ease of use, where 5 is easiest. So they really like that. And it does help with the clinical workflow, both from a timing point of view, but also from the point of view of making it a part of their regular everyday work. We found providers are reporting that they're doing more checks more often, which is a positive trend. And while some of this has been impacted by the lack of data, the COVID, the changing from in-person to telehealth and so on, but we are starting to see that providers are checking it earlier and that they're not just waiting till end of day or afterwards or whatever. So we're glad to see that. As far as the data goes, I pulled up some baseline numbers from last year when they had to use the portal. And you can see when the statutory requirement came out in January, statutory changes, that there was a spike in that, but in the amount of usage. But what you'll see is that over the year, the amount of requests dropped off. Again, this is because things took a while. It was impacting them. They're very busy. It's a challenge for them. So of the data that I pulled up thus far through June on the requests made to the controlled substance database from within the EHR, you'll see that those numbers, even without factoring in the actual portal checks, exceed what we were doing last year, and in general are starting to level out. The other thing is this line in here shows the number of providers that we're checking on a regular basis, and you can see that we have more providers doing checks on a regular basis. In the interest of time, I'm going to skip this next slide and go to what the providers are saying about it, and they do love it for the most part. I got a kick out of one dentist who commented when I walked into the room. He said, "This is the bomb." He said, "This is the greatest." He loved it. And we get that quite a bit, where providers will say, this is saving me a lot of time, I'm checking more often. But then we get another message that's coming across is providers will say, this is great, but when can we get other states' data? Or we have a couple of providers who tend to see quite a few out-of-state patients, and they basically have said, I like what you're doing, but I'm not going to use it until I have other states' data. So the message, it's pretty clear. And if you look and think back to our setting where we're right in the corner of the state, four states come together there, roughly 40% of our UNHS patients will live outside of Utah. So I just want to emphasize that we really need data sharing. And I say that again, that we really, really need data sharing. And just ask that states and vendors and whoever's involved find a way to share the data and to save lives. Just a couple other points that come more from my background in software development and architecture. One is that the user interfaces, from what I've seen both on screens and on reports, often tend to be very busy. It's like there's a contest to see how many items can you put on a screen. And it's kind of like some of my slides, but there tends to be a lot of scrolling. There tends to be a lot of conflicting UI. And some of this is by the nature of, if you have an EHR framework from one vendor and you've got an integrator, a different vendor who's plugging into that framework, without coordination, they will tend to have different styles, colors, fonts, etc. So that's just something to be aware of. If more coordination, that UI dissonance makes it harder for reading, but it also has an impact in terms of making actually the system seem slower than it may actually be. The other thing is in speaking of performance, one of the things that we've noted is, and this is kind of ironic, you're now saving the provider 3 to 5 minutes of the time they were in the portal, but now they're saying, hey, that 5 to 10 second wait is too long. We've got to pick that up. But one of the things we found is that with having multiple layers and multiple vendors involved, that there's often some finger pointing, some uncertainty as to where the performance issues are. And I would just encourage system architects, product architects to build in performance measurement, logging, configurable performance into the system and try to work with the whole stack so that you can identify things quicker and save some of the frustration for the user. And then one other thing, speaking about a frustrated user, I'd like you to look at this message and see how you would read it. If you get this icon and the message comes up and says, we couldn't get any patient prescriptions for your search, how are you going to interpret that? Does it mean that there's no records for the patient in the CSD? Or does it mean that there was an error trying to get the records? We've got quite a few support calls, emails about this. And as it turns out, this is just their way of saying, the particular vendor, that there are no records found. So that actually has caused support calls just by no records found. So in wrap up, a couple things. We really appreciate what we've been able to do, the help from the project, from CDC, ONC, from the state. It's a big step forward, but one of the other things that we need is we need some of that data to be able to be shared. It seems like there's a lot of protections and everything, but it's hard to provide timely feedback to providers on their prescribing practices when you can't get access to it. They may be able to get it. And for organizations who want to be able to provide training and some correction and guidance, they need that kind of data. But the other thing is that as you're building and designing these products, keep in mind that while the reports are great and they're helping, making it easier on providers, that the real goal should be moving towards a predictive clinical decision support, figuring out who's at risk, raising alerts right during the process, raising risk factors, those kind of things. So look for it to be predictive and proactive. So, and with that, I'll thank all those that involved, and we'll turn a moment over to Ron Larson from the state.
Thanks, Verlin. Appreciate it. Tough to follow up a great lead as Verlin, and I have to say that this project to get where we're at has been to a large part on his knowledge and experience and helping move things forward with several different players involved. For Utah, it's a homegrown system, and we're one of a few systems within the country that is providing and developing all of our interactive services within the state's DTS, Department of Technology Services, to try to promote and provide better communication with the stakeholders of the controlled substance database. With that being said, EHR has become a huge component of our future and trying to make sure that we can provide data in a reasonably accessible and I use the word seamless manner, but a streamlined manner that providers are able to very quickly see what's in the database and make those clinical decisions based upon the available information. And that may be not just prescription data, but then there's also other external records information, things of this nature. To Verlin's credit, he has helped bring, I think, a good deal of attention to the interstate data issues that I'm facing, and that is working with other states in their PDMP systems, but also with the laws that affect their PDMPs. So some states provide legislative mandated usage of an EHR where the state is paying for it. Utah believes in a system that is as low cost or free to the user as possible. When I say free, I don't know that there's anything free in a total sense, but we are wanting to make sure that it is accessible to all. Now, with that being said, we have to work with other states in trying to align our statutes with their statutes and providing that access in the different models that are available. So one of the things that I have to work on in the future and currently working on is literally working with the surrounding states. As Verlin mentioned, he's in the Four Corners. They receive patients from New Mexico, Arizona, and Colorado, and it would surely be nice to be able to provide that data in this EHR activity through each state, but that also means a unified effort by each state. One thing to note, when accessing the portal for the Utah Controlled Substance Database, we have agreements with these states so that providers are able to get that patient's data, but that meets its own challenges. Again, as he said, there's several layers. The different providers, the hub, state PDMP itself, what data will they allow and how will they allow it? There are definitely challenges ahead of us, but our commitment in Utah is to move forward and try to get as much of this data to the responsible hands as possible. We went from an old system to a new system, and in the next year we are looking to upgrade even further. You've heard of the ASAP reporting system. 4.2 is what we're currently at, going to go to 4.2B. So the American Society of Automation and Pharmacy's latest version, and we hope to have that out within the next year, along with other data elements that will help providers know the patient's history and challenges. I said in our earlier lead up to this, I wouldn't take much more time than that. But other than providing this help and looking forward to the several more integrations that has come as a result of this, we are now sitting with about 14 different clinics and moving on with several more. One of the big ones in Utah will be the Intermountain Health Care System, which we hope to have online and operational within the next month or so. I will turn it back over to Emily or Joanna.
All right, thank you all. Thank you for speaking to your experiences for the PMP EHR integration project. Next up, we're going to go into hearing from Bryn Rose and his experiences in teaching us about advances in opioid prescribing through health IT from the work that he's been doing with FHIR and C2L.
Thank you, Joanna. My name is Bryn Rhodes. I am a CTO of Dynamic Content Group, and I'm going to talk about several different projects that are all related to different approaches and to helping streamline implementation of guidelines like the opioid prescribing guideline. So this slide depicts the quality improvement ecosystem. This is a slide that a diagram that's included in several of the implementation guides that are coming out around this space. Typically, just what we're trying to get across is the data flow that comes from research, gets curated into guidelines. The guidelines are then interpreted as clinical decision support that's then deployed to hopefully improve clinical care. And then we use measurement and analytics to determine how we're doing. And that turns into reporting, public health reporting, quality reporting, safety reporting, and that ultimately feeds back into research and public health surveillance. And so ideally, that's a virtuous cycle that can continuously improves the quality of healthcare that we're delivering. So if you look around this ecosystem, specifically with opioids in mind, one of the this is recommendation 5, the text for one of the recommendations in the opioid prescribing guideline. So you can see that narrative description there. Another, an opioid-related quality measure, the percentage of patients aged 18 years that received opioid therapy, or perhaps a public health reporting event, detection of opioid substance in a clinical specimen by any method, or a cohort study. All of these are different manifestations of essentially the same underlying concepts. And so what we're trying to do within the implementation guides and the base fire specification is support expression of those different perspectives using fire resources and CQL for the logic involved. So this is a family of implementation guides that are all being worked on by different groups within HL7, and using as many of the specifications as we can to try to support not only the expression, but the exchange of that information across these boundaries and the delivery through standards like Smart on Fire and CDS hooks to the actual point of care. So another depiction of that layering, at the bottom here we have the base fire specification and the different modules that are included in that base specification. From that, we derive model IGs. So these are implementation guides like US Core or QI Core that are focused on describing a broad set of exchange use cases and supporting the exchange of data across as broad a target as possible within a particular realm. So international patient summary or US Core. And then implementation guides, specification IGs that are focused on describing how you use the different elements and standards in producing this kind of content that's shareable and evaluating this kind of content in decision support or quality measurement use cases. And then at the top, we have content IGs that actually are used to distribute. So the HEDIS IG, for example, would be a way to distribute HEDIS quality measures as fire resources. The CDC opioid prescribing IG, which we'll get into a bit more, is a way to distribute decision support rules that are characterized based on the opioid prescribing guideline, or say the WHO's antenatal care guideline. So one of the main implementation guides that we use in that space is called the Clinical Practice Guidelines on Fire, the CPG on Fire. And it's a way to characterize knowledge artifacts like quality measures or decision support rules, data elements involved in expressing those artifacts, the activities that you might do in a particular recommendation, so order a test or prescribe a medication, libraries of reusable logic that you can apply to when these things should happen or whether or not they should happen. And then recommendations, for example, avoid co-prescribing opioids and benzodiazepines. So that CPG on Fire is based on kind of a framework for how we talk about the different levels of knowledge representation. So level 1 narrative would be just a guideline for a specific disease written in the format of a peer-reviewed journal article. So that's the text-based description of the recommendation. Semi-structured would be things like flow diagrams or decision trees, other similar formats that are more visual or carry more structured information, but still not quite to the level of a structured document, L3, that contains a standards compliant specification with logic, data models, and terminology that's ready to be implemented. So this is a computer or machine readable representation. And then L4 is all the way to executable. So this is CDS that's implemented and used in a local execution environment. So if you take those levels of knowledge representation and you contrast those against the typical tiers of an architecture, a system architecture, at the bottom layer you have the data, at the top you have presentation, and then in between those you have a logic layer. And at each of these different levels, you'll have different manifestations of the intersection. So the narrative data might be glossaries or domain concepts, whereas the structured data would be actual terminologies expressed as fire resources or profile definitions. So we use that as a framework to say what kinds of things we expect to see in the different knowledge representation levels. And we'll walk through some of those. So in particular for these projects, we've taken an approach to the knowledge engineering that tries to integrate different capabilities and different skill sets on the same team. So we're not doing a waterfall from L1 to L2 to L3 to L4. We're doing an agile integrated approach that lets us move each of these things forward incrementally and with feedback from the stakeholders and ultimately the implementation sites. So we're going to talk about 4 different projects today. Just briefly describe some of them and then go into a little bit more detail on one of them. They're all based on the CDC opioid prescribing guideline. So the first one, and that's the link to the current guideline. The first one is called the ARC Pain Management Summary. This was work that was done, I think, almost 2 years ago now. It is a Smart on Fire application that is currently maintained and has been piloted in at least one pilot. Maybe 2. It's a Smart on Fire app that really focuses on providing the clinician with access to relevant information as driven by the guideline. So factors like risk factors associated with opioid prescribing, pain assessments, historical treatments, and this is built as a Smart on Fire app, but then carries CQL that describes the data elements involved that this Smart on Fire application displays. So that CQL basically pulls all of the information from a fire endpoint to display things like when they had their last treatment and when they had the most recent urine screening and whether they're pregnant and those kinds of risk factors all associated and expressed in a way that is completely independent of the UI that's being used to display that information. This summary just returns that data. And then we can pull all of these individual elements apart and look at how they're actually represented in terms of the base fire resources. So another project is opioid-related ECQMs. This one is a pre-rulemaking ECQ, electronic clinical quality measure, again, based on the opioid prescribing guideline. But this one actually uses milligram morphine equivalent calculator built in CQL that can be shared between the quality measure artifact here and the decision support that we've built up. So this is illustrating that by characterizing these in terms of a shareable logic, we can reuse that not only across different decision support recommendations and different sites, but different types of artifacts. Quality measures can share the logic between decision support and vice versa. So the next project is current. It's been going for about a year now, and it's to take the pain management summary that we just looked at and extend that with the notion of a shared decision-making session for chronic pain management between a provider and a patient. And it's using specifications like structured data capture to build a questionnaire. The patient fills out that questionnaire, that their responses are logged to the EHR, and then the pain manager application is able to retrieve those responses and display those as part of a shared decision-making session. So in particular, the requirement about displaying the questionnaire, we use the structured data capture, which is another FHIR implementation guide. It's particularly focused on questionnaires. And that is then made available. That's what that looks like. And then that is made available via a patient-facing Smart on FHIR application that can render any SDC form and present that to the user. The user then submits those, and because that's rendered as part of an application that understands how to build that questionnaire, we're actually building the L4 at the same time as the L3. We're able to extend that to the implementation side. And there are mappings that happen when that data is persisted, but that's part of implementation and separated from just the notion of the patient is filling out a questionnaire and providing answers to these questions. So that extractable questionnaire is the profile that enables that. And we submit that questionnaire to a FHIR endpoint that then does that mapping and turns it into data that's stored with the EHR. And then because it's part of the EHR, well, we can pull that information back out in the pain management summary and display that. So that the decision, and then we can add decision support capability from the opioid IG, including MME calculation as part of that application. So we've characterized all in this project, we're using all three of the layers of L3, but extending those to fully executable through Smart on FHIR and potentially CDS hooks integration as well. So the opioid prescribing IG, the content that we're using to do this, is an implementation guide that for each of the 12 recommendations goes through and provides more detailed information about how a site might implement that. In particular, we've worked with clinicians and terminologists to produce flow diagrams that illustrate what logic is happening and where and when, and how you might integrate this at the point of care based on a workflow event. We've characterized the data elements required that go into that logic, again, in more of an L2, and provided actual pseudocode for when the provider is prescribing an opioid analgesic and so on, then recommend avoid prescribing opioid pain medication and benzodiazepine concurrently. So that the data elements represent the lowest level, the lowest layer here, the data layer, and the L3. In particular, that looks like value sets expressed as FHIR resources, and FHIR profiles. So this is a medication request in particular that says these are the data elements that we need in order to accurately determine the dosing and timing information that we use to perform that MME calculation. So we're able to computably represent those data requirements. In the second layer, we have the logic libraries. So we have inclusion criteria here listed for the benzodiazepine, for example, and these are expressed as CQL and then wrapped up into FHIR library resources so that they can be shared just like any other FHIR resource. The recommendation then is what's called a FHIR plan definition resource, and one of the interesting things we can do there is actually link to computable evidence. This URL is actually the URL of a structured FHIR resource that contains computable representation of the evidence that's linked here. So one of the supporting evidence provided in the opioid recommendation 11 is a study that demonstrates patterns and deaths from drug overdose among U.S. veterans. So we're able to not only provide a link to that URL, but actually a FHIR resource that makes that structured as well. So that recommendation continued basically says when there's an order select, if the recommendation is applicable, again, that's the CQL we were just looking at, then perform this action. So get a description of the recommendation and present that to the clinician. So using those components, L3 artifacts as part of the implementation guide, we can do basically two different approaches to implementation, and these are both part of the current pilot. The first approach is to actually ingest those artifacts, the plan definitions and the CQL libraries, into a clinical reasoning enabled EMR or CDR. So it would actually pull the definitions in and then do some transformation to make that run in their rules engine or CQL evaluation. And so when that in this particular implementation runs on a warehousing, so it's a day after, but that's the approach there. Then the second approach is as a CDS hooks integration, a real time, where there's an EHR that can use CDS hooks and it will call out to a clinical reasoning implementation service that uses those plan definitions and CQL libraries to evaluate the recommendation and then return that as a CDS hooks response. And that is where my slides end. I'll turn it over to Jeannie.
Bren, thank you so much. So I'm going to try to talk pretty quickly here and go over one of the projects that we've worked with the Dynamic Content Group is CDS hooks for opioid guidelines number 10 and number 11. And I really wanted to talk about kind of like the reasons for the opioid clinical decision support and the reasons why I was really excited to participate in the CDS hook pilot and the grant. Some of the work that we did with kind of how we implemented that into our system and then the lessons that we've learned. So first thing to recognize is that there is a lot of need for clinical decision support. It's not in regards to opioids. It's not just for opioid use disorder. There's a lot of different areas where opioids are used, and we have to really think about how do I support all of the physicians caring for patients along that continuum. We did in North Carolina started with the STOP Act that was went into effect or part of it went into effect in 2017, and really ended up building out a ton of clinical decision support to support that requirement. And that included passive clinical decision support, structural clinical decision support, such as kind of building out our opioid prescription kind of navigator and clinical alerts. And the outcome of all of that, which I gave you one example here with our PDMP BPA, which is a best practice alert, was that it just took a tremendous amount of time and resources. And it really kind of brought home the message to me that it wasn't just a matter of that, everybody with an EHR should not have to recreate the wheel. Our PDMP BPA here, is integrated with our system and really includes, one click to look at it. It fires if you haven't reviewed it for this patient within the previous month. And it includes the resources of like how you should do safe opioid prescribing if you needed it. This is just kind of really just showing, though, that of some of our alerting that we did in our system, we have, like, for example, around 42,000 different BPAs that have fired for the PDMP. And that's just to remind our providers that they need to check that. And that doesn't necessarily mean that they looked at all of those BPAs. Some of them were fired into kind of one of our more passive formats, but it does really show that there are a number of needs for patients to get PDMP review. And so the outcome of all of this is that we really realized that, situational awareness, supporting situational awareness is really just making sure that the provider knows that this is a patient that's on opioids and that report needs to be checked. We also recognize the fact that you have to have reporting, and then you have to have an integrated clinical decision support. It's not enough to have like one portion of clinical decision support and another not supported, that it all needs to be on a continuum. So that brought us to the point of saying, what could we potentially do with CDS hooks that we'd be able to kind of share our information and share how that processes just Bryn went over in a more kind of a broad fashion, and can we gain some logic? And that's kind of what really brought us to the CDS hooks kind of format into the grant that we participated in recently. And really kind of the outcome here was that you have on the beginning end, you have the provider who's in the EHR. The provider says, hey, I'm going to order an opioid, or the patient's on an opioid. And then there's a message that goes out of the EHR, goes through kind of a FHIR resource, goes to a virtual machine that subsequently kind of chomps on the information related to the patient, and then says, okay, yeah, that patient has a recommendation or doesn't have a recommendation. And I just wanted to illustrate that there's multiple steps here and that it's really relatively kind of complex. What we found in our integration was that we really needed a lot of engineering support to set up the virtual machine, and that we really appreciated kind of all of the patience as we were kind of getting that set up. I think that's a concern for kind of how other people are going to extend this to other EHRs. We also developed the logic for the BPAs that initially kind of actually we reviewed the idea of like, do you actually build logic that kind of only looks at just the patients who potentially need it, or do you have it wide open so that all patients are investigated? And I'll come back to that in just a second as to the importance for that. And then we also kind of needed help with our Epic interface configuration. So we had help on multiple components as well as the CQF ruler. Our team of participants included an Epic build analyst, and as well as the Epic FHIR API interface analyst. We had operational team, which was the engineering team, which again kind of helped us to set up our virtual machine. And again, I think I want to highlight the fact that, this was partly a part of a byproduct of the pilot. I think if there was like a virtual format that could be interfaced, then a lot of those kind of engineering requirements would probably go away. We also had subject matter experts, as well as the dynamic content group that was doing work to set up the CQF ruler build and debugging, as well as project management. So this is an example of opioid guideline number 10, which is in regards to urine drug screen, the annual urine drug screen. And I just want to highlight the fact that, our approach here was to investigate every single point along of logic along where the flow sheets and be able to identify, is everything flowing correctly? And does it kind of end up showing an annual drug screen? But just to highlight the fact that, this is a really complex, logic here. I mean, I know it looks relatively simple, but what if you really go into it, it's really kind of saying, has the right, when you do a urine drug screen, what we ended up testing was just whether you had an annual urine drug screen. But the logic that really we would want to go into in the next step or iteration would be able to say, if a urine drug screen has been done, are all of the elements that are supposed to be on it, or all the elements that are not supposed to be on it? And that's really, really, really complex logic. So I think that really the CDS hooks really is interesting. It offers us a potential alternative to optimize alert-specific opioid clinical decision support in a format that might be extendable. But the interactive alerts require really actionability. What we really discovered through this pilot was that the current format for our FHIR app really is for only at the point in time when the chart is opened. And for really CDS hooks to be really effective, the FHIR app would really need to be able to work at all the other component times, such as putting in an order or removing an order, that is functionality that's already available in our alerting system. And so finally, kind of the lessons that we learned. Technical engineering expertise was incredibly important for our pilot to be successful, and we really required multiple members from our team member who were kind of doing active kind of understanding of where are the technically our messages are kind of failing and not going through. I do think that we kind of really did recognize through this pilot that there's trade-offs with CDS hooks. If we're going to open it up and potentially have the engine look at every single patient, then there may be, a significant amount of kind of overhead with that type of review, as opposed to, do you actually say, okay, we're only going to send these patients more restrictive review of the patients that get the CDS hooks review? Because at that point in time, if you're at that point, it's almost like you've already done a lot of the logic to kind of say, okay, well, what is the next step that we need to look at? We also recognize the fact that the standardization of the build in the EHR in regards to like LOINC codes and things like that are going to be incredibly important if we're going to be able to really kind of like extend the logic and be able to do more effective kind of clinical decision support. And that is all that I have to say. Got it in 10 minutes. Thank you so much. Joanna, are you taking over?
Yes. I'm waiting on Jamie to come in. We're going to hear from Jamie from SureScripts to talk with us about ECPS.
EPCS.
EPCS. Sorry, I'm tongue twisted. Long day.
Thank you.
Jamie, take it over.
Yes, thank you. And I know we have less than 15 minutes left, so I'll probably go through the slides pretty quickly so that we can get in at least one or two questions. So thank you all for sticking around for the final presentation of the first day. And let's begin. So I will be covering electronic prescribing as an overview, EPCS, electronic prescribing for controlled substances, recent data trends for national and state level trends for electronic prescribing of controlled substances, and then I'll touch on a case study conducted by researchers at the Office of the National Coordinator and SureScripts that analyzed EPCS use among Medicare Part D providers. So just at a high level, e-prescribing is the mechanism that allows a prescriber to transmit a patient's prescription from the point of care to a pharmacy that is the choice of the patient and via electronic means. So there's several benefits to electronic prescribing, including improved safety and security of prescriptions, such as two-factor authentication and ID proofing, and I'll go into those a little bit later, reduction of drug diversion, and increased prescription legibility, not having to decipher a provider's handwritten paper prescription, and improved care quality through enhancements in the ability to actually monitor the patient's prescriptions and have access to patient's prescription history. So e-prescribing can address many of the challenges that we find in paper prescriptions, including reduction in fraud that may be due to loose pads left on a prescriber's desk, ripe for theft and forgery by patients or even other prescribers. The increased likelihood that the prescription actually makes it to its final destination, and that would be the pharmacy. We've all had the experience of a crumpled up paper prescription left in our car or even washed in the laundry. That does not happen with electronic prescriptions. The prescription arrives at the pharmacy of choice by the patient, awaiting for the patient to pick up the medication. And lastly, electronic prescribing helps to meet the federal and state level e-prescribing requirements that I'll talk about next. So here we have several states that have rolled out e-prescribing mandates over the course of nearly a decade. We have the first state occurring in 2011. That was the state of Minnesota, and this was groundbreaking to be able to actually mandate that prescribers use electronic prescribing for both controlled and non-controlled substances. Well, this state didn't accompany a penalty for noncompliance, and we'll see the potential impact of that in the slides going forward. Next, 5 years later, we have New York's iStop Act, which is the Internet System for Tracking Overprescribing Act. This was groundbreaking because it really was housed under addressing the opioid crisis that we're still facing today. This act mandated that both non-controlled, again, and controlled substances be sent electronically, but now it accompanied a penalty. So this was really innovative for its time. And we can see that the subsequent states that occurred in terms of adopting these EPCS and e-prescribing mandates just occurred in succession. We've got Maine's EPCS mandate for simply opioids occurring in 2017, followed by Connecticut's EPCS mandate in 2018. And every subsequent state to date through 2020, 13 states total. Well, there are subsequent states that have pending legislation and have future legislation in 2021, 22, and 23 as well. And then we have the SUPPORT Act, the Substance Use Disorder Prevention that promotes opioid recovery and treatment for patients and Communities Act, which requires that Medicare Part D prescriptions for controlled substances be sent electronically by 2021. So to date, we have 31 states all across the country with some form of legislation either currently in place or a future legislative action that will take place. And here you can see there are a myriad of legislative actions, from all prescriptions to be sent electronically to simply controlled substances, and even more restrictive controlled substances, including opioids. And you can take a look and see the variety of states across the country and the variety of legislative authority there. So I mentioned electronic prescribing for controlled substances, but I haven't really given a background on it. So the DEA, the Drug Enforcement Agency, issued an interim final rule, an IFR, in 2010 that actually permitted prescribers to be able to prescribe controlled substances electronically. It required the two-factor authentication that I mentioned earlier, where you have one factor as a knowledge factor and the second factor as a biometric or hard token. You have the second, which is ID proofing, and that's really you are who you say you are, verifying that, and then logical access controls, verifying that the user has the authority to actually prescribe electronically. Interestingly enough, 1 decade later, in 2020, this year, the DEA reopened the IFR for comment, and there are a myriad of reasons, including, of course, minimizing drug diversion and, of course, the opioid epidemic. but also to be in accordance with the Support Act, which is, of course, to roll out EPCS for Medicare Part D controlled substance prescriptions by next year. And this was really to help understand the technological advancements between 2010 and 2020. There have been so many that have occurred within this past decade, and the DEA wanted to take those into consideration to help better advance the technology needed for this act. And of course, there's more information on that with the Federal Register. So overall, there's several benefits to using EPCS specifically to address the opioid epidemic. And we should all notice that this is a slide available on healthit.gov/EPCS, where it really highlights five key benefits: enhancements in patient safety, improvements in accuracy, reduction in fraud, and drug diversion. And I'm going to add one more here that's meeting those EPCS state and federal level requirements. So here I'll go into, again, the high-level overview of the national and state-level trends for e-prescribing and EPCS over time. Noted here is a link to the SureScripts National Progress Report that was issued earlier this year. It's a report that includes many of the metrics reported by SureScripts over time, and it's something that policymakers reference and also seek to actually get information from. So please go to that and visit it. So before I go into just the high-level network stats, I wanted to give a quick overview about SureScripts. SureScripts is the largest health information network in the country, and it connects virtually all electronic health records, pharmacy benefit managers, pharmacies, clinicians, many other entities as well. It's largely known for e-prescribing, but it has other services as well, such as medication history, real-time prescription benefit, electronic prescribing for controlled substances, electronic prior authorization, and other services as well. And the roots of the company actually date back about 2 decades. So to give you a lay of the land of the SureScripts network, I'll start here from the National Progress Report, which covers data from 2013 to 2019. And beginning in 2013, there were 6 billion transactions that flowed across the network. And those transactions included e-prescriptions as well as many of the other transactions that I just mentioned. By 2019, we've got more than 3-fold increase in transactions, from 6 billion in 2013 to 19 billion by 2019. And of course, the network continues to grow. Specifically drilling down into e-prescriptions and e-prescriptions for controlled substances. In 2017, we have 1.74 billion written electronic prescriptions, and that increased to 2.1 billion by 2019. We see even more substantial growth for electronic prescribing of controlled substances, where we have in 2017, 77 million, and that increased to nearly 160 million by 2019. At a high level, when we think about this in context of the nation, we've got 80% of all prescriptions going electronic across the SureScripts network in 2019, and that was up from 66% in 2017. 86% of all non-controlled substances flowed across the network, and that was up from 76% in 2017. And here we see a bit of a disparity where we have 38% of all controlled substances flowing electronically across the network in 2019, but that was still up from 17% in 2017. Here we can see, going forward with e-prescribing utilization and EPCS enablement, pharmacies are well ahead of prescribers. But still, about 79% of all prescribers in the U.S. were using electronic prescribing in 2019, and that was up from 69% in 2017. And again, we see a bit of a gap for EPCS enablement at 49% of all prescribers in the country enabled for EPCS. That was up from 22% in 2017. Here we have a snapshot of a really cool tool that's available on the SureScripts website. And it details EPCS, electronic prescribing for controlled substance readiness. And this is, of course, state by state. You're able to actually scroll across each state, and when you hover over each state, you're able to see the prescriber enablement or the pharmacy enablement for each state and the policy that's been implemented or that will be implemented in the future. Here we have New York highlighted at around 80% for prescriber enablement, and of course it highlights the New York iStop Act as well. We would be able to see other states if this were in our interactive mode. However, this is simply a screenshot, but please feel free to go to take a look at the tool on the SureScripts website. It's open to the public. So when we dive in to take a look at prescriber enablement by what's called what we're calling the first wave, and those are states from 2011 to 2019 that have implemented e-prescribing as a mandate, or e-prescribing for controlled substances as a mandate within the state. Here we can see that the trends are really flowing in accordance with the intervention dates for each state. So leading the way is New York, with New York's iStop mandate really taking off after the 2016 date of implementation and continuing to increase over time. Next, we have Maine, which again, we see at the implementation date of 2017, Maine prescriber enablement really taking off and then continuing to increase. Again, Connecticut with the same pattern, followed by Pennsylvania as well with the same pattern. Interestingly, Minnesota, which was of course the first state to roll out a mandate for e-prescribing, is the lowest in terms of prescriber enablement of the top 5 in the first wave. When we take a look at the second wave, we've got the states that have enacted their legislation or implemented their legislation for 2020. Again, we see a very similar trend. We see Arizona and North Carolina and Iowa really leading the way, again, with inflection points right around those implementation dates. For many states that actually had an implementation date that was earlier, you do see the prescriber enablement and prescriber adoption occurring, but then there may have been a delay, and then the state may have rolled out the implementation of the mandate 1 year after that initial date, and you still see continued adoption of the technology over time. So now we'll cover the last portion of this presentation, which is on electronic prescribing use among Medicare Part D prescribers. Again, a joint initiative by researchers from ONC and SureScripts, and I'd like to take the opportunity to thank the researchers at ONC who really permitted me to be able to present our work and also just provided this wonderful platform for us to talk about this very important topic. So the SUPPORT Act was passed by Congress in 2018. And again, this act required that controlled substance prescriptions covered under Medicare Part D are to be transmitted electronically by 2021. Initially, we started this initiative about a couple of years ago, and ONC issued a data brief last year covering dates 2015 and 2016. We updated the data this year to include 2017, and we had hoped that the data was going to be available for 2018 last month, but of course, likely due to COVID constraints, the data is not yet available, but please be on the lookout. We will be updating the data to include 2018 at the right time when the data is released. So here we have EPC use over time, EPCS use over time by Medicare Part D prescribers from 2015 to 2017. And we can see substantial growth, significant growth over this time frame, where 1 in 6 providers who are Part D used EPCS in 2017. And we see the growth between 2016 and 2017, where the proportion of Part D prescribers who used EPCS increased by 45%, and the proportion of Part D opioid prescribers increased by even more between 2016 and 2017 by 62%. And we expect to see this continued level of growth in 2018, 19, and 20 as well. Next, we have EPCS varying by the number of Part D opioid claims, where we have 3 in 10 Part D prescribers who had no opioid Part D claims, but 1 in 10 of those providers did use EPCS. 1 in 8 Part D prescribers had more than 100 Part D opioid claims, but more than 25% of those prescribers used EPCS. So overall, the Part D prescribers with more than 100 Part D opioid claims used EPCS at higher rates. And this is what we would expect to see as well by specialty. Here we have pain management leading the way, where they have the largest proportion of Part D prescribers using EPCS, and they also have the highest number of Part D opioid claims per prescriber. And then subsequently, we see behavioral health and oncology and geriatric really leading the way as well in terms of having the largest proportion of Part D prescribers utilizing the technology. Again, we see a very similar trend to what we saw 3 years later in 2020. But in 2017, we see that Maine and New York really lead the way. Notably, of course, in 2016, we have the rollout of the iStop mandate, and in Maine, we have the rollout of Maine's EPCS mandate in 2017. And so we see that the Medicare Part D prescribers are really following that trend of adoption and utilization, following those state-level mandates. And lastly, again, just noting that growth in percentage point, Maine increased from 3% to 52%, a 48 percentage point increase, really large, likely driven by the Maine EPCS mandate. So when we think about the barriers and some of the adoption barriers for EPCS, there's several that we found. Some being cost concerns, many also just about education gaps and understanding that, yes, you can actually prescribe controlled substances electronically. I've had several providers actually approach me after presentations and just noting that they were surprised to learn that they are able to prescribe, that it is legal to prescribe controlled substances electronically. And then also understanding those processes for the two-factor authentication, the logical access controls, and ID proofing. We have a website, getepcs.com, and other resources that can really help providers to navigate that process as well. And then there are others such as just misinformation about prescribing, understanding the requirements for each state's state-level mandates. Those are also gaps that really can be addressed by educating providers as well. So at a high level, we've covered that EPCS use has many benefits, security and safety, as well as efficiency for prescribers and for patients. We clearly see that there's work to do still. We know the gap between the 86% of all non-controlled substances going electronically versus 38% of controlled substances going electronically. So there's still more work to do. But despite these challenges, Medicare Part D providers are still using the technology. We saw that growth between 2015 and 2017. And again, we expect to see that continued growth in 2018 through 2021 as we approach the SUPPORT Act. And this is very promising for the rollout of the SUPPORT Act. Many are concerned about whether or not these providers will actually adopt the technology by 2021 or even 2022, but we really have evidence here to show that these providers are adopting the technology, and it's actually in accordance with the general population of providers. So we see that pattern, and we see it really translating over to the Medicare Part D prescriber population. And then lastly, the impact of these state-level mandates. We see New York and Maine and Connecticut really driving the way for prescribers in adoption overall, and then we also see it translating right around the time frame of those mandates rollout over to the Medicare Part D population as well. So these are just a list of a few EPCS resources that are available. The data briefs, the EPCS map, the Get EPCS website for more information, and of course, the SureScripts National Progress Report. Thank you.
Oh, I'm still on mute. Jamie, thank you very much for your presentation. And after that, I definitely can say EPCS after that nice long break. Thank you so much for sharing all of your information with us. And I just want to say thank you to all our presenters that presented today. Unfortunately for our participants, if you all have not sent your questions in, we have ran out of time to respond to the questions. But if you can get it in really quickly, I think your email pops up and we'll try to respond to it by email. Thank you for those who've already submitted your questions, and we look forward to hearing from you. Again, if there is something else that you need from us, you have our names, you have our bios, and by emailing one of us, I'm sure you can get in contact with us. Hopefully this was an informative session for you, and don't forget to complete the survey tomorrow, and we look forward to hearing from you all or seeing you all tomorrow. Thank you all for a wonderful, wonderful session.